There was a paper that I was reading about, and I wanted to kind of go over this information just so people have an idea. And it was done by Incel DX, and when we were talking about the blood markers that they found, I just want to kind of read them off. A summary of the paper. Uh, it identified the following markers for people with actually the algorithm when training was capable of predicting with 97% precision who is a severe COVID-19, who is a severe case of COVID-19, a long hauler, and a non-severe non-long hauler. After, in the testing split, this predictor was 100% precise with a 100% recall. So, in summary, the paper has identified the following markers. Interleukin 2 is significantly elevated in long haul COVID. This is a type of cytokine signaling molecule that regulates the activity of white blood cells. 2. Interleukin 4 is significantly elevated in COVID long haulers. This is a cytokine produced by mast cells that induces differentiation of naive helper T cells. Number 3, CCL3 is significantly elevated in long haul COVID. This is a chemokine involved in the acute inflammatory state. It also recruits and activates polymorphonuclear leukocytes. Polymorphonuclear.
That's a good one.
Leukocytes. Sorry, that's a big one. Interleukin 6 is significantly elevated in long COVID. This is a type of cytokine secreted by macrophages that stimulates the production of neutrophils in the bone marrow. Interleukin 10 is significantly elevated in long COVID. VEGF is significantly elevated in long COVID. This protein stimulates the formation of blood vessels. And this is what I found really interesting. GM-CSF is significantly decreased in long COVID. GM-CSF is a cytokine that promotes neutrophil proliferation and maturation. Number 9, CCL4 is significantly decreased in long COVID. In addition, there were 3 extra findings. There was no evidence of T-cell exhaustion. Long haulers, mild and severe cases all showed elevated CCL5. And B cells, CD14, and CD16 monocytes subsets were significantly elevated. So that is an interesting list. And I know that most people aren't immunologists and don't know what a lot of that probably means. But to simplify it in a way, those are a lot of different cytokines and immune functions that are out of regulation. And so in many ways, what's happening is you have a bunch of dysfunction, and we don't exactly know why you have this immune dysfunction. What needs to happen, to simplify, is somehow to modulate the immune system to where it goes back to normal. And there are a number of different ways to do that. I found interesting GM-CSF was decreased significantly in the COVID long haulers patients. Why? Because we use a lot of GM-CSF for our cancer patients. We use it instead of something called GCSF, which we still use some GCSF, but GCSF is also called Neupogen, and it's what you give cancer patients when their white blood cells drop tremendously. The problem that we have with GCSF is that it tolerizes DC, so it tolerizes dendritic cells. And when you have a cancer patient that has an immune system that their white blood cells have dropped tremendously, and then you give them GCSF, you'll get a spike in their white blood cell count. But if you're tolerizing the dendritic cells, you're hurting the biggest chance for a patient to get a tumor response. Your dendritic cells are what's called antigen-presenting cells. So they present the tumor antigen or the viral antigen to the T cell, and hopefully you get a memory T cell response, and the memory T cell does the final killing of the cancer or the virus, so then it remembers it. So, by having a decreased amount of GM-CSF, my first thought is, of course, we need to talk to our scientific advisory board and our doctors, but, it's logical to give somebody GM-CSF. And you have experience as well, at least not experience treating with GM-CSF, but you've seen it in being used in a lot of patients. When you read that, what did you think?
Well, in talking to you and talking to some of the other doctors, it's been really interesting how much crossover there is with the way we've been treating cancer patients for years now, and trying to tackle the problem in a similar way. So at first level, it was similar symptoms, but then digging into the chemistry and the biology to hear that there's so many other things with T cells, cytokine, that are crossing over. That's what's exciting for me, is that we have experience with that, and being able to put that experience to work to try to help these people out.
Yeah, we were working on a protocol with some of our team, and thinking about ways to run clinical trials, and we want to be one of the first to run a clinical trial using stem cells and COVID. Stem cells have a number of different effects that could possibly help COVID long haulers patients. But, when we're doing these trials, and it's great that we do trials. I love doing trials and getting the data. But my problem with the way the system has always been is it's a singular approach. And I do not believe in monotherapy in general for people. Generally the best is combination therapy. How can you combine different substances to work synergistically together to get the best possible response for the patient?